This is Brian Gill, and I'm going to be discussing our chapter, Microsurgery of Distal Anterior Cerebral Artery Aneurysms by Brian Gill, Jason Ellis, and Sandra Connolly. The objectives of this presentation are to review the anatomy of the distal anterior cerebral artery, discuss the clinical presentation and the workup for patients with DACA aneurysms, and finally to present the different approaches and microsurgical options for these lesions. The distal anterior cerebral artery refers to the region of the anterior cerebral artery that lies distal to the communicating segment. This area can be broken up into 4 segments and contains 8 major named cortical branches. The infracallosal segment, or A2, which projects from the A1 anterior communicating junction and ends at the genu of the corpus callosum after giving rise to the orbital frontal and frontopolar arteries. The precallosal segment parallels the genu and gives off the callosal marginal artery, which is the major arterial branch of this region, in addition to the 3 internal frontal arteries. The A4 and A5 segments course over the body of the corpus callosum and are divided by a vertical plane defined by the coronal suture. They give rise to the paracentral and parietal arteries, respectively. Anatomical variants of the distal anterior cerebral artery include the presence of an unpaired A2 segment of the ACA known as an azygous ACA, a bihemispheric ACA in which a single DACA supplies both hemispheres, or the presence of an accessory A2 segment in which there is triplication of the A2 origin. These anomalies are seen in 35% of cases of distal ACA aneurysms, and so it behooves cerebrovascular surgeons to be aware of this variant anatomy. DACA aneurysms arise along the ACA distal to the communicating segment. They are usually less than 5 millimeters in size, and in comparison to other locations, are commonly traumatic or mycotic in etiology. Likely as a result of its morphologic characteristics, they have a higher propensity for rupture and a greater operative morbidity than other anterior circulation aneurysms. These lesions often present in the setting of a subarachnoid hemorrhage and are commonly associated with a concomitant intracerebral hemorrhage, which may explain why patients with subarachnoid hemorrhage secondary to a ruptured DACA aneurysm have an increased incidence of poor clinical grade presentations. In our practice, we generally use both volumetric CT angiography and catheter angiography to diagnose and delineate the anatomical features of the aneurysm and its associated vessels. Volumetric scans, such as a fine-cut CTA or MRI, may also be helpful for preoperative planning and allow the surgeon to determine the relationship of the aneurysm to the surrounding structures. Additionally, they can be used in conjunction with frameless stereotaxy for intraoperative localization of the aneurysm. Depending on the location of the aneurysm along the distal anterior cerebral artery, it can be approached via a standard frontotemporal craniotomy or a parasagittal craniotomy. Frontotemporal or terional craniotomies with a lateral subfrontal approach may also be used to treat aneurysms in the A2 and A3 segments of the distal ACA. The parasagittal craniotomy, when combined with an interhemispheric approach, can be used to treat most DACA aneurysms and can be tailored as necessary to reach the different segments of the distal ACA. Infra or precallosal aneurysms can be reached from a low frontal parasagittal craniotomy, while more distal lesions can be reached from a craniotomy placed posterior to the coronal suture. With the help of intraoperative navigation, the exact location and size of the craniotomy can be modified to account for draining veins. At our institution, we prefer the parasagittal craniotomy for its flexibility in approaching DACA aneurysms. Patients are positioned supine with the table placed in slight reverse Trendelenburg to facilitate venous drainage. For aneurysms that are infra or precallosal, the head is extended slightly. A bicoronal incision above the temporalis muscle is used, and a generous craniotomy approximately 6 centimeters in length and 5 centimeters in width extending across the superior sagittal sinus is fashioned. This ensures that the operative surgeon will be able to navigate the venous anatomy and find the route to the aneurysm. Broadly speaking, there are 2 microsurgical options for the management of DACA aneurysms. Clip reconstruction is the most common method used and works well for the majority of small to moderate-sized saccular aneurysms. However, this method is not always feasible, particularly when the aneurysm in question is large, fusiform, traumatic, or if it has a calcified neck. In these rare instances, Microsurgical bypass may be performed to preserve distal flow, and then the aneurysm can be treated with a variety of methods, including excision, proximal or distal occlusion, or trapping. For a more detailed review of the microsurgical maneuvers needed for clip reconstruction, please see the short operative video associated with this chapter. Briefly, following the parasagittal craniotomy ipsilateral to the aneurysm, we make a dural flap with a broad base on the superior sagittal sinus. We then use frameless stereotaxy to help us identify a trajectory for the interhemispheric dissection to the aneurysm, which will help us preserve the patient's venous anatomy. Exposed cortical surfaces are then covered with Surgicel or cottonoids as the medial frontal lobe is mobilized away from the falx. Beneath the free edge of the falx, sharp subarachnoid dissection is used to separate the medial frontal lobes. Particularly in the case of ruptured aneurysm, CSF diversion via an external ventricular drain or lumbar drain placed prior to surgery can facilitate the development of this interhemispheric corridor. The callosal marginal arteries and then the pericallosal arteries are identified, and the latter are followed proximally until the aneurysm and its parent vessels are identified. Once proximal control is achieved, the aneurysm can be clipped in line with the parent vessel in order to prevent kinking or crimping of the associated vessels. Vessel patency and the adequacy of the clipping can then be checked with intraoperative angiography, ICG, and Doppler ultrasonography. In conclusion, DACA aneurysms arise after the anterior communicating segment of the ACA. They have a high propensity for rupture and a greater operative morbidity than other anterior circulation aneurysms. The parasagittal craniotomy and the interhemispheric approach are the workhorse for DACA aneurysms, and volumetric CT angiography or MR imaging should be obtained prior to surgical intervention in order to help plan the ideal intraoperative trajectory to the lesion. Clip reconstruction and microsurgical bypass with subsequent aneurysm treatment are the two major microsurgical techniques used for the management of these lesions. Clip reconstruction is by far the most common method used, with bypass reserved for especially complex aneurysms.